So screening of diseases means that there are some unrecognized cases within apparently healthy individuals which went unnoticed due to whatever reason and is being detected via a screening process. So we'll be talking about screening versus diagnosis. Screening is always done in healthy individuals, while diagnosis is always done in cases. Okay, that is, cases which have sufficient suspicion of having a disease, while screening is done in people with no suspicion. And it is applied, screening test is not an individual test, it is indeed a test of groups or a particular subset of populations or the whole population. Doesn't matter, but it is basically more than one individuals that are tested together, and that is called screening. While in diagnosis, we are just testing the individuals. Whoever comes to the clinic for a particular complaint will be given a diagnostic test for which the results will provide with a provisional or a confirmatory diagnosis. Okay, so test results. Now the test results that I just talked about, like every screening or diagnostic test will have a result. So what about the test results? So the test results are final in cases of screening. For example, if a person comes positive in any screening test, we usually do not refer them for a confirmatory test. We just say that this is the final test. But it's, however, arbitrary. Arbitrary का मतलब होता है कि even though it's final, it doesn't mean that it is always true or it is always correct. Maybe a screening test could be wrong and it is not used for diagnosis, but it is said that if a person comes positive under a screening test, then usually you do not go for any other tests. Rather, you refer that person to a doctor, and the doctor will decide what diagnostic tests to run. While diagnostic tests, these are not final, okay, and these are modifiable. Now what does this mean? This means that the tests, for example, if the doctor prescribes a screening, not a screening test, but diagnostic test, and the doctor has a suspicion that maybe this screening test might be wrong in some way, then the test can be modified, or the test can be done again, or there could be other tests that can be run on the patient for confirmation. So it's modifiable. So the results are modifiable. Okay, now you have so basically your screening tests will be based on only one criterion, while your diagnostic tests will include more than one criterion. Why? For example, if you look at screening test for diabetes, they will only look at random blood sugar, while if there's a diagnostic test that is done for diabetes, they will look at random blood sugar, they might look at your fasting blood sugar, and more importantly, they'll also look at your HbA1c. So there are a number of tests and a number of criterion that they will follow in order to call a person a diseased person. Okay. Next you have time taken. Since I told you that the results that come is final and arbitrary. So since I told you that the results of a screening test is final and arbitrary, so that will mean that a screening test will take less time because the results are arbitrary, but it's also final. So there won't be any other further testing that is done. Instead, whatever result comes is final. Okay, so that's why one more difference is that it takes only less time. So less time taken. While in cases of diagnostic tests, what happens is more time is taken, because to arrive at a diagnosis, a lot of criterion is used. Not just one criterion, but multiple criterion is used. So it will take more time. Now, other differences between screening and diagnostic tests. So the cost of the screening test will always be less, while it will be more in cases of the cost will be more in case of diagnostic cases. Also the accuracy, again I told you that the results will be final, but it will be arbitrary. What does arbitrary mean? That the results are not accurate. So accuracy in screening tests is usually inaccurate, while the accuracies in diagnostic tests can be relatively more accurate. So it is more accurate, while screening tests results are inaccurate. So do you think that the results of a screening test can be used? Screening test results can be used for basis of treatment? I don't think so, because there are many reasons. First of all, the uh, the tests are arbitrary, results are arbitrary, they are inaccurate, takes less cost, it's usually takes less time, and only one criterion is used. So we usually do not take the results of a screening test as a basis of treatment. So we don't take screening tests as a basis of treatment, but the diagnostic test is taken as a basis of treatment. Now, who takes the initiative to do a screening test? Usually usually a person goes to the clinic or doesn't go to the clinic, and for example, he goes to the clinic and he complains that he has some fatigue or some other issues, and the doctor will prescribe him a TB test, though it is completely unrelated or maybe very remotely related to the symptom in question. Still the doctor will prescribe a TB test. That's called prescriptive screening. We'll come to that. While in cases of, so the initiative is taken by the investigator, either the investigator or the initiative is taken by the government. It could be anybody. But if you see here, for screening, the initiative is taken by the patient himself. So, sorry, for diagnosis, the patient himself wants a diagnosis, wants to get treated for the disease that he's suffering from. So he initiates the whole thing. So diagnosis is the initiative is from the patient. The patient visits the clinic, tells the doctor that he has this problem, and the doctor then prescribes the diagnostic tests. So that is the difference between screening and diagnosis. So different principles of screening has been prescribed by the WHO. So the first is, for screening for a disease to be done, the disease should be a very important health problem. What should it be? It should be an important health problem. It should not be a rare endemic or rare disease, like for example, not like some rare disease like neurofibromatosis. You usually don't do screening tests for rare diseases, but you do screening tests for important health problems that impact the society. For example, TB. So TB is a very important health problem. So is COVID, right? So these are examples of diseases which are important health problems and they impact the society. So we do screening for such and such diseases. Next, you have whatever diseases that we are screening, whatever diseases are to be screened should have a treatment. Should have a treatment. For example, if you are screening for an autoimmune condition, autoimmune conditions usually don't have a treatment. So screening for them is usually not advised. So we don't usually screen an autoimmune condition, but we do screen diseases which can be easily avoided. For example, anemia. So the treatment is very simple. You need to give iron and folic acid. So we do screening for diseases which are easily treatable or there's an effective treatment for the disease. Third criteria is that even if a treatment is available, okay, there should be facilities for diagnosis and treatment in the country. It's like, for example, there are many diseases which are very rare, and they also have a treatment, they also have an effective treatment, but that effective treatment is not present within the country. Instead, this effective treatment is present outside of the country, and the medicines have to be imported into the country for treatment. So such diseases cannot be taken up for screening. So even though they have an effective treatment, there has to be facilities for diagnosis and treatment within the country. Then there should be at least one early asymptomatic stage of disease. Asymptomatic stage. because screening का मतलब ही क्या है? We are trying to detect the cases in unrecognized people or unrecognized cases. For example, diabetes. It has a asymptomatic period, a long asymptomatic period before which all the symptoms of diabetes start appearing, like polyuria, polydipsia. All these things start appearing after a long asymptomatic period, long latent period. So it will be useful for these diseases to be detected earlier. So that's why screening is done. So it should have an asymptomatic period. For example, some diseases, they don't have an asymptomatic period or a very small incubation period. So there is no point screening those diseases, because those diseases will eventually show themselves in a short amount of time. So if it's a short incubation period, the disease will show itself and there won't be any need for screening. So screening is done only in cases with asymptomatic stage or a long latent period. Also, there has to be a screening test available for the disease which can help screen the disease earlier, and the test should be acceptable to the population. It should not be some weird invasive test or very it should not be like a very costly test or something. It should be acceptable to the general population. The general population should not have a problem with getting those tests done. So these are the different criteria for screening. So first of all, what are the criteria? Let's choose another color. Yeah, so one is, it should be an important health problem like TB and COVID. Then whatever disease is screened should have a treatment, an effective treatment. For example, autoimmune conditions usually don't have a treatment, so we can't screen them. Anemia, in fact, has a good treatment, that is iron and folic acid. However, even though there is an effective treatment, faculties for diagnosis and treatment should be available within the country. It should not be an exotic disease for which the treatment has to be important from another country. Also, there has to be an asymptomatic or latent stage, as in diabetes, where there's a long asymptomatic stage after which the symptoms start appearing. If a short incubation period disease is there, there's no point in screening because the disease will show itself within that short amount of time, and screening is not needed in such diseases. Also, there has to be a screening test for the particular disease in question, and the screening test should be acceptable to the population. So these are the principles of screening. Okay. We'll come to types of screening. So screening can be of two types. One is prescriptive screening, as I mentioned earlier, and then there's a prospective screening. So the difference between the two is that in prescriptive screening, the people, they are screened for their own benefit. For example, if a person with diabetes or a person who has a propensity of getting diabetes, or the risk factors for diabetes, comes to the physician will prescribe a screening test in order to give benefit to the patient, not for the population. But for example, a person is a sex worker, and that person is known to have, maybe has a risk of having HIV or gonococcus infection. Now, what will the doctor do? The doctor will screen the sex worker for the benefit of the whole population, because the population who visits the sex workers will be contracting the disease, and they will become the bridge population for disease transfer. So that's why there are two types of screening, as I already told you. There's a prescriptive and there's a prospective. So prospective screening is for the benefit of population, while prescriptive screening is for the benefit of the patient in question. So the examples are quite clear, I hope. Next, you have essential purpose. Now, what is the purpose of the prescriptive screening and the prospective screening? So this is the first difference. Second is, what is the purpose? Now, the purpose is to detect a case. While the purpose in case of prospective screening is to control disease or control the spread of disease. As I told you, for example, if a sex worker is screened for HIV, and if she has HIV, then she can be, prevented from working in that particular environment, so that she can prevent, so that there can be prevention of HIV transmission, and there's a break in the chain of transmission. So here we are trying to control the spread of particular diseases, while in cases of prescriptive screening, we're just trying to detect a particular case and give the treatment to that particular case in question. Next, you have request for screening. Now, usually, if you look at the prescriptive screening, there is no specific request from any authority or the government. The government doesn't tell the doctor to screen a case for their own benefit. But a government or an authority will tell the doctor to screen somebody for other people's or for the whole population's benefit. So there is a request from the government for what? For prospective screening. So a few examples will clear it out. For example, in prescriptive screening, neonatal screening. Neonatal screening for neonatal tetanus or pap smear. Guthrie test, you must have heard of Guthrie test. And there is also heel prick test, all those tests for neonatal screening. Pap smear for cervical cancer. This is all for the benefit of the patient. For example, if I do a pap smear in an adolescent girl or a girl of reproductive age, we are actually preventing cervical cancer in that particular girl. Okay, cervical cancer is not a spreadable disease, so we are not doing any benefit to the population. We are only doing benefit to that particular patient. So that's why it is a prescriptive screening. Then we have urine for sugar. Again, if we detect the urine for sugar, doesn't mean that the population will be benefited, only the case will be benefited. But in cases of communicable diseases, for example HIV, screening for HIV in sex workers, or screening of immigrants, we're actually preventing new diseases from emerging in the population, or we are actually protecting the population by doing prescriptive and prospective screening. Now there is a few neonatal screening tests that you should know of. So first, neonatal. So we are going to talk about what diseases we are going to screen in cases of neonates. Okay, so neonatal screening में आ जाता है. First is hypothyroidism. So we are going to screen the neonate for hypothyroidism. How do we do that? See, hypothyroidism is the most common neonatal disorder to be screened in India. Okay, so all over the world actually. So neonatal hypothyroidism, it is the most common disease to be screened. Most common neonatal disease. So every child born in an institutional setting will get a hypothyroidism screening done, regardless of their consent. And then we have blood sample of choice. So what blood sample do we usually use? Blood sample used is umbilical cord. Umbilical cord. And what do we test? We usually test TSH. Okay. We usually test TSH and we test T4, not T3. Okay. Now we have the next disease, which is phenylketonuria. As I told you in the above this thing, there's a test called Guthrie test for this. Guthrie test, it's not done nowadays though, but it is the first screening test used in, it was the first screening test, okay, it was the first screening test ever used for neonates. So it was done after 3 days of life. Okay, after 3 days of life, because Guthrie test is always negative in less than 3 days of life. Okay, it's positive in only more than 3 days of life. It is negative in less than 3 days of life. That's why we always do the Guthrie test after 3 days of life. Okay, so what does Guthrie test usually detect? So it detects first of all phenylalanine, phenylpyruvate, and phenyl lactate. So it detects what? APL. So it detects alanine, it detects pyruvate, and it detects lactate. The phenylalanine, phenylpyruvate, and phenyl lactate. So these are the three chemicals that Guthrie test usually detects. However, nowadays Guthrie test is replaced by tandem mass spectrometry, which is a more sophisticated test. So the Guthrie test is now replaced by tandem mass spectrometry. Also, The three diseases that Guthrie test usually detects is, that we'll have to know. One is phenylketonuria. So phenylketonuria is one test. Another one is galactosemia. And the third one is maple syrup urine disease. So what is the enzyme that's detected? I told you three chemicals: phenylalanine, phenylpyruvate, and phenyllactate. But what enzyme is detected in Guthrie test? So there's also an enzyme that is detected, and that is phenylalanine hydroxylase. Phenylalanine hydroxylase. So this enzyme is also detected. So these are the two tests that you should know of. So first is neonatal hypothyroidism. So neonatal hypothyroidism is a very important test that is done in almost all neonates throughout the country, and the most common is also the most common neonatal disease to be screened. And the blood sample is taken from the umbilical cord, and the test detects TSH and T4. Then you have phenylketonuria, which is used to be detected by Guthrie test, which is now replaced by tandem mass spectrometry. So Guthrie test is the first screening test ever to be employed for neonates. It is not done in less than 3 days because it is negative in 3 days, less than 3 days. It is always done after 3 days. And what three chemicals does it detect? One is phenylalanine, phenylpyruvate, and lactate. Then you have the Guthrie test, which is now replaced by the tandem mass spectrometry, which is more accurate and more sophisticated. Now Guthrie test also detects three diseases, which is phenylketonuria, galactosemia, and maple syrup urine disease. And the enzyme that Guthrie test detects is phenylalanine hydroxylase. So this is about neonatal screening. So criteria in screening: